So my outline is developing the question, how did we start to get so interested in lymphatic anatomy? Talk about some of our early investigations. I know Angela yesterday already talked about the R01. I'll just briefly go over that, just talk about some of our current aims on that R01. I know Stephanie yesterday talked about the U54, so I'll probably skip over a lot of that, but highlight one part of that U54 and make a concluding remark. My goal, and yank me off whenever my time's up, my goal is to finish early and make sure we have time for discussion, because that's what I think is most exciting. All right, so developing the question. So the question of lymphatic anatomy actually came to me based on what we were doing clinically. And so a large focus of my work, even before I started doing lymphatics, was breast cancer reconstruction. So taking care of breast cancer patients who were getting mastectomies. And obviously, there are about 3.8 million breast cancer survivors in the US, and that number is it can move depending on how you look at it. And about 1 in 5 will go on to develop lymphedema. And I don't need to tell this audience how much of an impact lymphedema can have on a patient. And while lymphatic surgery, lymph node transplant, lymphovenous bypass, or even debulking for the treatment of lymphedema can be very promising, as can be shown here with significant improvements in quality of life, as well as quantitative improvements, and being able to reduce the amount of compression therapy a patient's wearing. I don't think there is a single lymphatic surgeon that walks around claiming they can reliably cure patients, okay? I know the word cure is being thrown in a little more, and we have our cures in our center. That said, we don't use that routinely, nor do we ever ask patients to have that expectation when they walk into. They can have the expectation, but we won't operate on them if that's what they're expecting us to deliver, because I'm not ready to say we can deliver that reliably. So if there's not a cure, I got very interested very early in my career as an attending on prevention. And we know that lymphedema is a progressive disease. And so the question became, well, in the US, we're causing this in the operating room. The number one cause of lymphedema is nodal dissections. And specifically in breast cancer, it's axillary lymph node dissection. So the question became, why can't we try to prevent this in the operating room? So I went looking to see, in medicine, whenever you think you have a new idea, you're wrong. You just didn't look far enough in history. And I actually didn't have to look very far. This was 2015. I was down at the University of Florida, and I looked in the literature, and just a few years earlier, these surgeons in Italy had come up with this idea that they termed lympha. And what they basically said they're going to do is they're going to go in, let me see if there's a pointer here, and try to point things out. There you go. So what they said is, look, when we go in, we know removing axillary lymph nodes is the number one cause of lymphedema. So when we go in, we're going to actually go ahead, remove those lymph nodes. But before we do that, we're going to inject a blue dye in the arm. We're going to find those blue lymphatic channels, and we're going to reroute them into a vein, basically making a mini thoracic duct right there in the axilla. And by doing this, they had their rate of lymphedema down to 4%. Against historical controls, which was about 26 to 33%. So this was like a big deal. Not many people believed them, and a couple of us in the US started doing this, and now we have data corroborating a lot of their work. So we became very active in doing this. This was the work I did with Lisa Spiegel, who is the breast surgeon I work with down in Florida. We wrote about this, about our technique. And we started writing about all our outcomes when we came to Boston. And how am I going to tie this into anatomy? Give me a second. And then we did something really, really important in policy. We approached Blue Cross Blue Shield, and we got the first policy in the US covered for lymphatic surgery procedures. So no insurance company had a written policy to cover lymphatic surgery until we worked for a year with Blue Cross Blue Shield, Massachusetts, and now they cover lymph node transplant, lymphovenous bypass, and debulking. But here's the big but. They refuse to cover prevention. And their argument for not covering prevention was they said, well, Dhruv, what you're telling me is that this procedure will prevent 1 out of 3 or 4 women from getting lymphedema. Until you can figure out who that 1 out of 3 or 4 women are before you go to the OR, we're not going to cover this. So that led to the question, well, why is it that only 1 out of 3 women or 1 out of 4 women who get an axe dissection and radiation get lymphedema? What's saving the other 2 or 3 women? And that's what ultimately drove us to our research. So I did a meta-analysis earlier and just showing this, that if you look at all comers, this was a meta-analysis of 3,000 patients in the literature. If you take an axillary node dissection and regional lymph node radiation, the 2 highest risk factors for developing lymphedema, and looked in the literature, only 33% go on to get lymphedema. And so what's going on with the other 2/3? And I really think this is a $1 million question. And I think this is a $1 million question because if you can figure out who's going to get lymphedema at the time of a cancer diagnosis, think about all the things we can do, surgically and non-surgically, to make sure that patient doesn't get lymphedema, right? It's mind-boggling. And I think it's a complete paradigm shift. I think if we figure this out, and I'll tell you, James texted me, and you all met him yesterday. I think he's sleeping right now and catching up on rest. But he texted me, and he said, Dhruv, we will figure this out. You know, we have a very focused question, and I really believe we will, or one of our sister teams will, but as a community, for patients, we will figure this out. This will be a complete paradigm shift. Because what's going to happen now is one of us, could be a therapist, could be a lymphatic surgeon, will sit on these tumor boards and say, okay, that patient needs an axillary node dissection. They have a 100% risk of getting lymphedema because of X, Y, or Z. And we'll talk a little bit about what the X, Y, or Z is in a minute, or what we think it might be. And so we need to either not do an axillary node dissection, go to another modality, or we need to make sure they're in a good surveillance program, which we should be doing anyway, but this patient in particular. Or maybe I'm going to show up in the operating room and do a prophylactic lymph node transplant on this patient, meaning I'm not just going to do a bypass on them. I'm going to go get lymph nodes and reconstruct their entire lymphatic system while they're on the table, because I know they can't tolerate the axillary node dissection. So I do believe from a clinical standpoint, this research has the potential of completely shifting how we approach lymphedema in this country and around the world. So that's how the question came about. And then what were our early investigations? So if you look in the literature, so that was a question. Why do 2 out of 3 women or 3 out of 4 women not get lymphedema after the exact same insult in the operating room and after the operating room with radiation? And if you look in the literature, there's 2 theories. One is genetics, meaning in this room, assuming nobody in this room has, or let's say in this room, some individuals have a genetic predisposition to lymphedema, whether or not you have lymphedema. So if you have that genetic predisposition and you get cancer, and then they treat you for cancer, you are going to spill over into lymphedema. So it's predestined in a way when you were born. That's one of the theories in the literature, but it just doesn't hold the weight statistically when you look at the numbers and the variations that have been found to explain it. The one that's more exciting to me as a surgeon, and I think the one that makes more sense, is lymphatic anatomy variations. We know there's a lot of variability in the human body. We know there's variability in the arterial system. We know that variability increases when you go to the venous system. And we know lymphatics bud from veins. So that scope of variability is going to increase even more when you get to lymphatics. Ultimately, I think the answer to this is going to be both of these. However, I do think the driving force is going to be anatomy variations. And so this is our 6th year running the symposium. It was in our very first symposium, 2017, an anatomist from University of Montpellier, Alexander Pisas. He was not invited faculty. He called our organizers And I remember they came to me and said, this gentleman with a very strong French accent says he wants to come and give a 5-minute abstract on lymphatic anatomy. And we talked to him. We said, listen, we don't have the funds to bring you here, but if you want to come, we'll give you the stage. And his work actually is what drove me to a specific pathway, which is called the MS pathway, or the lateral upper arm pathway. And then that's shot off into all the things James talked to you about yesterday. And so he got up and he said, look, what Dr. Pisa said is he feels lymphedema is a 2-hit hypothesis, meaning patients get axillary node dissections and they do fine for the most part. But then he had these series of patients where they had skin cancers or some trauma right over here. And as soon as they took out a little piece of tissue here, the patient blew up into full-blown lymphedema. And he said he was an anatomist, and he said he went into the lab, into the anatomy lab, and there's this pathway called the MS pathway, which travels right along the cephalic vein, and he felt that that's a collateral pathway. And if you damage that collateral pathway, and the patient had an axillary node dissection, the 2 hits, they're going to develop lymphedema. And remember, we had a very healthy discussion at that symposium about this anatomy, and one of the conclusions was, we got to learn more about it. And that's what my focus became. Soon after we recovered from that symposium, I remember I was sitting in my office. It was a weekend. I remember very distinctly. It was pouring rain outside. It was a 3-day weekend, and I was looking up the SAPI pathway. And one of the beauties of being at Harvard is SAPI wrote a textbook in 1874, and I called Countway Library, which is our main library. And I remember talking to the guy on the phone, and I said, I'm looking for a PDF of the 1874 SAPI textbook in French. And there's rustling in the background, and he goes, why don't you come on over, we have it. And I just remember my jaw dropped. I was like, you have a textbook from 1874 in French from Paris? And he's like, yeah, it's in the rare books collection. And so I literally ran over. I still remember running behind Brigham and Women's Hospital from BI to Conway Library. And there I was in the rare books collection. I remember they guard you when you walk into this collection because these books are old. And I was like, can I take pictures of this? And they were like, yeah, sure. I was like, can I touch it? They're like, yeah, flip through it. I just couldn't believe I was there. And so this is the textbook. This is one of I think there's only a few of these left. One of the original textbooks from SAPI, 1874. There's the imprint on the inside. Again, I just couldn't believe it. I felt like I was a kid in a candy store. And here it is. SAPI described this in the 1800s. Miscagni also described this in the 1700s. He says, if you look here, all these arm lymphatics go right into the axilla, but look right out here. There's another pathway that completely avoids it, and that's what he called the Miscagni, or later became known as the Miscagni-SAPI pathway. And so the question became, is this what's preventing women from getting lymphedema? So these anatomists have theorized this for a long time, but nobody had really looked at it with real-time imaging. And I remember I was at the ISL in 2017 as well with Kathy, and I took Hiro Swami aside, and I said, Hiro, yeah, for those of you who don't know, Hiro is a colleague of our colleagues from Sydney, and he's a world leader in anatomy. And I said, Hiro, I need to start visualizing the MS pathway. How do I do it? And I remember he just looked at me. He's like, I'm not sure. And we talked about it some more. And he's like, yeah, an injection next to the cephalic vein probably makes the most sense. So that's what we started doing. So we had all these women coming in for prevention of lymphedema. So we were taking them to the OR, and we were rerouting their lymphatic system. But before we did that, we started injecting right over the cephalic vein to map the lymphatic system. And we wrote about our experience here. And what you can see here, we picked this picture because you can see the cephalic vein right here, and you can see how the pathway goes right alongside it. And Hiro came in 2018, and he dissected out upper extremity for us, and he just showed us the MS pathway. So you can see all these arm lymphatics are going here, but look right here. There's the MS pathway. And here's what we can do right in our clinic. We can bring a patient in and inject dyes and see this in real life. We don't need to do cadaveric dissections here. We can locate this now right in our clinic, in our near-infrared imaging room. And then Kubik in 1950, another anatomist, noticed in cadavers that when he dissected these lymphatics, and you have to understand, dissecting lymphatics in cadavers takes months. It's not something you can do very easily. He noticed that there were two kinds of MS pathways. There were these pathways which he called long bundles, and then we were able to replicate it on our imaging, where this bundle connects from the upper arm to the forearm. And then there's something called a short bundle, meaning if you inject the hand and wrist, which is usually how we start, nothing connects up here. But if you do a separate injection right over the cephalic vein, the pathway is there. So this is what we call a short bundle, short versus long. And it was theorized that a long bundle was likely good, because you can imagine if you undergo an axillary node dissection and you wipe out all these pathways here, well, now you have an ability to reroute up this way. But in this patient, if you wipe out this pathway right here, well, now you're stuck. It's got nowhere to go. And this is where I think genetics may play a role in the future, because we know we can regenerate lymphatics, but maybe it'll be the size of the gap or one's innate ability to regenerate that says whether or not they're going to recreate this connection. So this is imaging we can do right in our clinic, showing you what a long bundle pattern looks like. So we'll inject in the hand right here, and you can just see right away. Boom, it connects up. There's your MS pathway. There's your pathway going to the axilla, and here's your connection right here. So it's pretty straightforward. But then you get the short bundle scenario, again, showing you what it looks like here, where you did all these injections, nothing connected up here. We had to do a separate injection over the cephalic to get this additional pathway to light up. And there's your gap right here. And then in the worst case scenario, the patient actually has no MS pathway at all, meaning you do the injections, everything goes here, nothing up here. You do a separate injection over the cephalic, and you get no MS pathway. So we started looking at this, and in 60 consecutive patients, we noticed 2/3 of women had a long bundle. 1/3 had a short bundle, and very few, it was only one patient who had no bundle at all. So, and these numbers started, these numbers sound familiar, don't they? This is starting to get close to the incidence of lymphedema. So then we went back and looked at these patients that we had imaged, and even though only 1/3 of the patients had a short bundle, turns out and they did not have lymphedema. I can't say they did because they didn't, but when we went back and looked at 7 that had anything that was concerning for lymphedema, an elevated LDEC score or a volume trending in the wrong direction, we noticed that 2/3 of them had the short bundle. And so that really is what led us to say, okay, I think we're onto something, and we need to put this into a grant. We wrote to the NIH, and we were awarded an R1 to further study the MS pathway. And this is a shout out to LE&RN. LE&RN has been doing a lot of work to push forward the lymphatic agenda with the NIH, CDC, and I can't imagine that didn't play some part in my ultimate and our team's ultimate success in getting funding for this project. So we are funded by the NHLBI, and we have basically, as Angela talked about yesterday, Angela is our lead coordinator for this study. So please reach out to Angela if you have any questions about it. You have people you think might be interested in this. We are basically mapping healthy female volunteers coming off the street, and we're mapping the lymphatic system using ICG, and then we're chasing it with nuclear studies led by Dr. Kevin Donna, who's speaking right after me, and he's right over there in the bow tie, who's an amazing collaborator in all of this, and I'll show you some of the imaging he's kindly given to me to show you. And we also are taking, very importantly, breast cancer survivors who had an axillary node dissection but never got lymphedema, and we are bringing them in to see, well, how did their lymphatic system reroute? And I do want to give a shout out to Cheryl Alphonse and their team at MGH, who have really partnered with us. We just care. We just want to get to the answer here. We don't care which institution we're at, and I love that about how we work. And they've worked with us to get us volunteers for this. So Cheryl, thank you very much to you and your team for your help on this. We also have an animal part of this project where we're trying to measure real-time lymphatic flow. So you can do what you need to do, whether that's MLD or CDT, and you can actually hopefully one day inject them or give them a drug and then get a number that will tell you how well you've changed the real-time lymphatic flow. And that's what we're working on with swine. I'll just show this image here from the R01. It's a very much color-coded. It's color-coded based on lymphosomes, which is something that was taught to us by Hiro. I just want you to see here, these are two different patients, volunteers. You can see their MS pathway has different colors. It means their MS pathway has different contributions. So we're seeing a lot of variability in this. And I know James went into a lot of the details on symmetry yesterday, and this is what he was referring to. This is part of what he was referring to when he went over that. We also are seeing a lot of variability within individuals, between one side and the other side, when we do injections over the cephalic vein versus also hand injections. And this is, Kevin was really nice to make a video out of this for us, but you're gonna see the variability in the two axilla within a single individual. And we're currently working on getting this to manuscript phase as well. The benefits of being part of the study, obviously patients, volunteers get to learn about their own anatomy. Maybe one day we can link things to genetics. And obviously this could play a role ultimately in prevention. And again, I want to give a shout out to Angela. This is her phone number if you want to call her. We are very motivated in getting volunteers for this study. We went on, so the MS pathway was one of the pathways, but then there's another pathway. And I'm preaching to the choir here because I know people, as CLTs, you're trained in this, but as surgeons, we're learning more and more about this, is the tricipital pathway, or the Kaplan's pathway, the pathway in the posterior upper arm. And so one of the great things that happened, COVID was not great in any way, but some of the things that came out of COVID was our need to rely on Zoom and other virtual platforms. And so as we started studying the tricipital pathway, we found that Kaplan, unfortunately Kaplan had passed. We literally as a team were looking up these anatomists to see who was still alive. And it turned out Kaplan had passed, but his disciple, Professor Ciucci from Buenos Aires, was alive. Now he only spoke Spanish. So fortunately, one of our research fellows at the time, Valeria Bustos and Jaime Pardo, both spoke fluent Spanish. So over a course of probably 20 hours, maybe 10 meetings with Professor Ciucci, he taught us a lot about the tricipital pathway. And then we started doing real-time imaging of the tricipital pathway in the lab, and we started finding very similar things of long bundle scenarios, short bundle scenarios, and in rare patients where the pathway doesn't exist at all. And we found the same thing, different contributions from different parts of the forearm, where the ulnar side in particular seemed to be giving most of the contributions. And we also found different terminations. The tricipital pathway is supposed to come in posteriorly in the armpit. And we found sometimes it did, sometimes it actually swung to the front of the arm and connected with a main pathway going to the armpit. So you can imagine, and these are theories, but maybe this isn't such a good thing. Because if you have an node dissection, well, that pathway suddenly isn't doing very much for you, versus if it goes in the backside, maybe it's still preserved after an axillary node dissection. And we're looking at, again, more variations of the pathway. How am I doing with time? Am I doing okay? Yeah. So this is, and then I'll play this video. This is, and I think there's a little delay on the video, but this is just showing the tricipital pathway in real-time imaging in the clinic. This is just for orientation. We're looking at the back of the arm now. This is a long bundle scenario, again, where you can see we do hand-wrist injections. And you can see the connection. This is what Ciucci taught us. This is what he called the external variation, where you can see the connections here to the tricipital pathway. And there's a connection. And here's a short bundle scenario where you do your injections. Sorry, I don't know why it's going slow. And then it's only after the tricipital injection that we actually see the tricipital pathway. So there's no connection here. And then the last one will basically show you that there was no tricipital pathway at all. And that was just our injection. All right. And then, so that we got funded for that in 2021, and then in 2022, we got a U54 grant from the NIH, and this is our grant that's focused on lymphatic anatomy mapping throughout the body. And I got very motivated for this grant because it dovetailed into what we were doing with the R01, and I know that Stephanie has already introduced this yesterday, so I'm not gonna go through all these slides. I'm actually gonna skip through the slides, but I don't know if she showed this. I don't think she did. I just wanna give a little context here about where we are in our understanding of lymphatic anatomy. So if you wanna go back and find a compendium on, let's say, arterial anatomy, right? There's probably a new one that comes out every couple of years, some major textbook. If you wanna do that for lymphatics, you have to go back to 1787, Scagni, 1874, Sappi, 1938, Rouvier. And that's where the story ends. There is not a single compendium of lymphatic anatomy after that. It just shows you the big blind spot that exists in terms of lymphatics. And I do not want to take away any credit from our modern anatomists who are working on this. Hiro, Swami, Kubik, Leduc, they're doing incredible work. But in terms of being able to bring it all together into one framework that we can all learn from, we're quite outdated. And so why is that? It's just a fascinating question I've thought about all of them. Why is it that we've, in a way, ignored lymphatics for so long? Well, I think it actually comes down to a quote I heard once. It said, the eyes only see what the mind knows. But I think the reverse is true. The mind only knows what the eye sees. And the lymphatic system's invisible. That's the problem. So if you look at this, at the capillary level, like the end level, at the end of arteries, veins, and where lymphatics start, right? It's actually ironic. The blood system is 20 times smaller than the lymphatic system. Okay, so at the capillary level, lymphatics are huge. But the story completely reverses after that. If you go look at the biggest artery in the body, it's the aorta, it's 2 centimeters, 2 to 3 centimeters, same with the vein, IVC. But if you look at the biggest lymphatic in the body, it's 2 to 4 millimeters. So we're 1 logarithmic scale smaller in the lymphatic system. The other thing that makes the lymphatic system invisible is this. The blood is red. So even, I'm a microsurgeon, so even if I cut across a 0.5 millimeter artery, it's gonna ruin my day because blood is gonna go everywhere if I don't control it ahead of time. But you can go through 100 lymphatics, wouldn't even know it. The thing that's made the difference, and I've watched this before my eyes with prevention, is you put a drop of dye into the lymphatic system, and the breast surgeon looks up at the screen and they go, did I do that? I'm like, yeah, you did, but you're saving the patient's life. But yes, this is the collateral damage that's being caused when you do that. And it's really as simple as that. If the eye can see it, suddenly you care about it, and now we can see it. So we care about this more and more and more. Okay, I'm not gonna go through this. I know Stephanie went through this, Stephanie went through this, Stephanie went through this. And I just wanna give a call out to our spatial technology team at BI, led by Yanis Vlachos, first time in human history that we know of. This happened in the late summer. We did single nucleus RNA sequencing of a human lymphatic vessel, and that's never been done before. And when you think about getting to that level, so he's taking these cells, he's looking at what's happening to the proteins to each of these cells, but then how they are associated with one another you just can see how 20 years from now, how we could potentially have drug targets, how we can learn how the lymphatic system's interplaying with the fat around it. It's a very exciting beginning, and we just feel, we pinch ourselves sometimes to have the opportunity and the funding to be able to do this. All right, so in conclusion, we think lymphatic anatomy variations will profoundly impact patient care ultimately. I want to thank our core team. We meet every Wednesday at 7 a.m., spend an hour going over cases, and we basically talk all week by cell phone, text, anything under the sun that's going on. I want to thank them, our research team that does incredible work and has really a passion for what they do. And if you're interested in more, you can, about the research, you can go to singhalab.com. Otherwise, these are my 3 most important team members. They're my kids up in Maine. Thanks, and I really hope there are questions and we can chat. Thank you. Do I have time for questions?
Well, we have one question online that's sort of anatomy adjacent.
Yeah.
Coming from yesterday. And the question is, how can we find doctors who conduct ICG, I think for diagnostic purposes?
Yeah. I think for diagnosis, I think that's a great question. And in 2017, I remember I was at the IASL with Bill and Bill Rapisi, who's the president and CEO of LE&RN. And we actually sat down and we were talking, and he was telling me about a big problem he had. And the big problem he had was that patients were contacting LE&RN and saying, I heard there was a lymphatic surgeon out here. I called that lymphatic surgeon, and they screened me on the phone. They told me I wasn't a candidate, and then I have nothing. What do I do? And Bill's like, we gotta change this. And I was sharing with Bill what I shared with you is how we were building teams. And he was like, well, we've been thinking about centers of excellence. And so that is what actually reinvigorated the Center of Excellence movement. And so I think my short answer to that question is, I think, leaning on these designations is really important, because these designations, we had 1,000 pages plus to our application to become a Center of Excellence. They're not taken lightly. Once you're designated, you're expected to deliver certain things. ICG is one of them. So I would lean on those Center of Excellence designations.
I don't know if we have any other questions in the room.
Great. Thanks, everyone.